Different degrees of enlargement of spleen. Mild, up to 2 fingers, or just palpable spleen, spleen tip. Acute malaria. Acute cholera. Enteric fever. Acute viral hepatitis. Subacute bacterial endocarditis, SBE. Miliary tuberculosis. Acute leukemias. Hemolytic anemia. Immune thrombocytopenic purpura, IDP, Feltes syndrome. Infectious mononucleosis. Weil's disease. Moderate, 2 to 5 fingers or up to the umbilicus. Chronic malaria. Chronic cholera. Portal hypertension. Lymphoma. Chronic lymphocytic leukemia. Collagen, vascular diseases like SLE. Congenital hemolytic anemia, example thalassemia. Huge or massive, 5 fingers or greater than 7 centimeters, or when the spleen crosses the umbilicus, chronic cholera or chronic malaria. Thalassemia major. Chronic myeloid leukemia. Tropical splenomegaly syndrome. Polycythemia vera. Portal hypertension with hypersplenism, in cirrhosis. Extrahepatic portal vein obstruction, EHO. Myelofibrosis or myelosclerosis. Storage disorders, Gaucher's disease, amyloidosis, splenic cyst, tumor, or abscess. Hepatosplenomegaly. Chronic malaria. Patient comes from an endemic zone with high rise of temperature associated with chill and rigor. Fever may come on alternate days periodically. Severe anemia, mild jaundice, may be present. Spleen, moderate to massive enlargement, firm to hard and non-tender. Diagnosis is confirmed by demonstration of malaria parasites in the peripheral blood. There may be leukopenia. Chronic cholera, patient comes from an cholera endemic zone. Double rise of temperature, double, quotidian, in 24 hours may be present, 20% cases. Appetite is preserved in spite of fever and loss of body weight. Spleen, massively enlarged, soft to firm, often a doughy feel, and non-tender. Spleen of chronic cholera is softer than chronic malarial spleen. Liver, moderate enlargement, firm and non-tender. Ratio of liver and spleen is 2:5. Alopecia, pigmentation. Diagnosis is made by neutropenia, positive aldehyde test, direct agglutination test, DAT, or by demonstration of LD bodies in buffy coat preparation of blood or bone marrow smear or splenic puncture. Thalassemia, Cooley's anemia. The patient is usually a child or young adult with positive family history. Stunted growth, typical mongoloid facies, massive splenomegaly with moderate hepatomegaly, severe anemia, mild jaundice, leg ulcers over malleoli of foot. Diagnosis is done by microcytic hypochromic anemia, reticulocytosis, anisocytosis, poikilocytosis, target cells, IL, hemoglobin electrophoresis, HbF greater than 2%. 3. Radiological study of skull and small bones of hand. Acquired hemolytic anemia, example autoimmune, may produce hepatosplenomegaly. 4. Cirrhosis of liver, postnecrotic. Features of chronic liver disease, example dyspepsia, malaise, wasting, severe weakness. There may be past stage/O jaundice. Symptoms and signs of hepatocellular failure. Features of portal hypertension, hematemesis, melena, splenomegaly, venous prominences over abdomen, ascites. Mild to moderate hepatomegaly with moderate splenomegaly. Both are firm and non-tender. Presence of other stigmata of cirrhosis of liver. Diagnosis is done by demonstration of esophageal varices, splenoportalvinography, liver biopsy. Chronic myeloid leukemia. The patient is around 30 to 80 years, peak, 55 years, with fever, dragging pain in the left hypochondrium and profound weakness. Weight loss and sweating are due to increased metabolic rate. Anemia, mild sternal tenderness, present. Hepatosplenomegaly spleen, hugely enlarged, hard with occasional splenic rub, may be tender. Liver, mild to moderate enlargement. Diagnosis is confirmed by 1.5 to 2.5 lax WBC/MM3 with myelocytes, metamyelocytes, promyelocytes, and few myeloblasts. AML, mild splenomegaly, all, moderate splenomegaly CML, huge splenomegaly, CLL, moderate splenomegaly. Lymphoma. Progressive painless enlargement of cervical, axillary, or inguinal lymph nodes, fever, loss of weight, pruritus, weakness, drenching night sweats. Superior mediastinal syndrome may be present, dyspnea, engorged non-pulsatile neck vein, swelling of face, tortuous veins over chest wall. Spleen, moderately enlarged, non-tender. Liver, moderate enlargement. Anemia, eosinophilia in blood may be present. The lymph node biopsy is confirmatory. Acute viral hepatitis. H/O jaundice preceded by anorexia, profound nausea, fever, and occasional vomiting. Urine is yellow and stool may be of white colored. There may be urticarial rash, arthralgia. Hepatosplenomegaly, mild to moderate, tender hepatomegaly with mild splenomegaly, soft. Diagnosis is done by high serum bilirubin, high SGPT, ALT, alkaline phosphatase, slight rise, prothrombin time estimation, may rise. HbAg anti-HAV or anti-HEV, anti-HCV in blood. Enteric fever, H/O rise of temperature in step-ladder pattern, frontal headache, constipation, epistaxis, rose spots in skin, relative bradycardia. Tongue, red margins with central, coating, angry-looking tongue. Spleen, soft and tender, just palpable spleen at the end of first week. Liver, soft, non-tender, mild enlargement. Diagnosis is done by neutropenia, blood culture, and Weidel test. Polycythemia vera symptoms like headache, fullness in head, pruritus, peripheral vessel thrombosis, due to increased viscosity of blood, visual disturbances commonly in a middle-aged male patient. Epistaxis, hematemesis, or melena, pruritus, peptic ulcer, peripheral vascular bleeding. Face is plethoric, conjunctivas are congested, and palms are red. Spleen is enlarged in 75% cases and may be massive, hepatomegaly in 30% cases. Diagnosis is made by raised hematocrit, low ESR, hyperplasia of all marrow elements in bone marrow examination. Erythropoietin level is decreased. Collagen, vascular disease, SLE. The patient is mostly a woman with fever, arthralgia, alopecia, oral ulcer, skin rash, or lymphadenopathy. Renal, lung or cardiac involvement, oliguria, pleurisy, pericarditis, dyspnea, i.e., multisystem disease. Spleen, usually there is moderately enlarged, firm, non-tender spleen, diagnosed by high ESR, positive anti-nuclear factor, antibody to double-stranded DNA and anti-SM antibody, SLE, renal biopsy etc. Tropical splenomegaly syndrome, previously known as Banty's syndrome. The patient comes from a hyperendemic area with an exaggerated immune response to malaria. The disease is common in females, and has familial and racial predisposition. Adults have high malarial antibody titers with low parasitemia. Spleen, massive splenomegaly. Liver, mild to moderate enlargement. Signs of portal hypertension may be present without any evidence of cirrhosis of liver, due to increased portal blood flow. Chronic low-grade hemolytic anemia may be seen, low-grade pyrexia. Diagnosed by increased level of IgM, sinusoidal lymphocytosis in liver biopsy, diagnostic. The mode of nomenclature of the disease is hyperreactive malarial splenomegaly. Myelofibrosis or myelosclerosis. This may be primary, or develops from toxins, malignancy, lymphoma, irradiation, secondary. Spleen, massive, tender spleen, splenic rub may be present. Hepatomegaly, mild to moderate enlargement. Leukoerythroblastic blood picture with high platelet count. Bone marrow examination may not yield any result, dry tap, and often refined biopsy is needed to demonstrate the fibrotic changes. X-ray shows ground glass appearance, osteosclerosis, of all bones of axial skeleton. There may be signs of hemorrhage into the skin. Felty's syndrome. It is a subgroup of rheumatoid arthritis with splenomegaly and neutropenia. Age of onset is around 50 to 70 years and more common in females. Features like weight loss, joint pain with deformity, lymphadenopathy, pigmentation, leg ulcers, vasculitis, chest infection, keratoconjunctivitis sicca, rheumatoid nodules may be present. Spleen, mild splenomegaly. Diagnosis is done by anemia, neutropenia, thrombocytopenia, and strongly positive rheumatoid factor. Miliary tuberculosis, gradual onset with vagal health, high fever with drenching sweats, pallor, loss of weight. Cough, breathlessness, anorexia, headache may be present. Tachycardia, paucity of signs in the chest, few crepitations in late stages. Mild, non-tender hepatomegaly with small palpable spleen. Signs of meningeal irritation may be found. Choroidal tubercle may be visible, 25%, on ophthalmoscopy, diagnostic. Chest X-ray shows miliary mottling bilaterally. Leukocytosis is usually absent. MEN2 test may be negative. Sputum examination may or may not demonstrate AFB. Amyloidosis, presence of long-standing suppurative focus in the form of lung abscess, bronchiectasis, chronic osteomyelitis, or may develop from tuberculosis, Crohn's disease, multiple myeloma, lymphoma, leprosy, rheumatoid arthritis. Visceromegaly, macroglossia, tongue becomes stiff and firm to palpation, hepatosplenomegaly. Evidence of nephrotic hypercholesterolemia. Syndrome, albuminuria, hypoproteinemia, anasarca malabsorption, lymphadenopathy, peripheral neuropathy, cardiomyopathy may be present. Liver, gingival, abdominal fat, or rectal biopsy is done and gives positive Congo red test.